Thank you, Nigam. And thank you for having me here today. Um, one of my friends, and it's not Nigam, another friend says, I'm cheap, lazy, and parasite because I don't generate data, don't run any clinical trials, and only use publicly available data. And I tell him, no, I'm frugal, efficient, and symbiotic. It's a point of view, right? um, uh, Data is data, and then what you do with it, that's really important. And when I was asked to give the grand rounds, I really struggled as to what topic to talk about. And I can probably give the same talk on many different topics. So as you see it today, you would see it's about data science, machine learning, AI. It's about team science. This wouldn't have happened for somebody who's never picked up a pipette to actually be able to go to patients without a lot of people in this room actually enrolling patients, trying it out in clinic, and so on. So it's many different ways that you can think about this, and hopefully it will come out. So most important, I'll be talking about some of the work that we ultimately ended up doing at Informatics. So I'm a co-founder and a consultant for Informatics. I won't be talking about anything else today, but that's the most important disclosure today. I don't think I need to. So I could have talked about a lot of different diseases, and then ultimately I sort of said, let's just talk about one story that really highlights data science, team science, all of that happens in this department. And really, Nigam was absolutely right when he said you have to stay at medicine. That was the reason I decided to stay in medicine, because I couldn't see being able to do this anywhere else. Infectious diseases, 21st century, still the largest, one of the leading causes of mortality worldwide. Sepsis, most expensive line item in Medicare. 1 in 5 global deaths every year because of sepsis. Excuse me, I'm recovering from flu. Speaking of infectious diseases. And we still cannot. Again, this audience does not need these data points, but we know that even in 21st century, when we can sequence to the nth degree, we still cannot find pathogen in radiographically confirmed pneumonia. 2/3 of the patients, we still cannot detect what is the pathogen that's actually causing that infection. And the reason for that, again, this audience knows, patients that come walking through ED, ICU, they are very ambiguous, very heterogeneous patient population. 3 sources of variability: biological, age, sex, race, ethnicity, what you eat, what your lifestyle is. Oops, why is this not moving? There. Comorbidities, all the clinical comorbidities that you can imagine, autoimmune diseases, immunosuppression, different treatments, all of that introduces more heterogeneity. And then if it is infection, most of the time it's not in peripheral blood, it's not in circulation, it's usually in one of the organ system. And when you can detect a pathogen, knowing where the infection might be, that becomes even more challenging. So as I was transitioning to a faculty position, during my postdoc, which was also in pediatrics here at Stanford in solid organ transplant, the first time I learned about immune system, it was really remarkable to sort of come to realization what a privileged status immune system has had during evolution. This is the only organ system that's allowed to be mobile. Only organ system that actually has an exclusive access to every other organ system. You can't, if your heart fails, you can't create a new heart, right? Kidney fails, thank God we have 2, but if both fail, you can't create a new kidney. These organs can walk over to each other and talk to each other. Immune system surveils the system over the entire host. And when a threat is detected, it can expand, respond, and when the threat goes away, it contracts. No other organ system can do this. We think of evolution in terms of millions of years. But in every one of us, from the day we are born to the day we are to the day we die, immune system constantly interacts with environment, learns what we are exposed to, and remembers what we are repeatedly getting exposed to. So it has memory, and it's a time evolution that is on an individual's lifespan scale, not millions of years. So given this very privileged status, sort of almost 15 years ago now, the hypothesis was born that immune system holds the key for improving diagnostics, especially infectious diseases, because immune system has been seeing pathogen. One of its most important function over the millions of years of evolution has been identify what's not self and get rid of it. So it knows what kind of what is not self, whether it's a bacteria, virus, parasite, fungi, and it not only it can identify that, it knows what is the right response for it is. So we can, if we can somehow read the immune response in peripheral blood, we don't need to look for a bug. We can just ask the immune system, hey, what are you responding to? And that can basically tell us whether it's a bacterial infection, viral infection, and so on. And it can work for any emerging pathogen. It does not have to be a pathogen that it has seen before. When COVID-19 came around 5 years ago now, it was a virus, and immune system sort of knew what sort of immune response it should have. And in majority of the people, 80% of the people were fine, although it was a new virus. And we also predicted a few other things that would happen, that if immune response is not adequate, there would be, we could re-stratify, look at immune response and say, you will have a poor outcome, you'll have a good outcome. We might be able to do predict who will respond to what treatment. And I'm going to walk you through all of these examples today. And this is not a new idea. I mean, if you go back and look at when was the first time host response was proposed for use in clinical practice, lactate was 180 years ago, almost 2 centuries ago. And we are still using that today for prognostication, to predict what whether somebody would have severe outcome or not. CRP more than 40 years ago, PCT another 30 years ago. So we've been using host response more as a protein biomarkers for almost 2 centuries now. And when I was a postdoc, right around the time when I was about to transition to faculty position, a lot of transcriptomic data had been collected in NCBI data repositories. So the question was, what's the next thing that we can use instead of one or a couple of using 1 or 2 proteins? And the hypothesis, excuse me, 15 years ago was, I think it's going to be mRNA. We should be able to use mRNA as a diagnostic at point of care. But if we are really going to use immune response at point of care as a diagnostic and measure it, quantify it through mRNA, we had one big problem, and that is the heterogeneity in immune response for the diverse group of patients that present in ED. And all of these things, again, this audience knows, right? Not everybody shows up in ED at the first sign of symptom onset. Some people wait. I still haven't gone to, I self-diagnosed myself and said, well, I have flu or some viral infection, it will go away. So I've never even shown up. People who usually show up are immunocompromised, worried about having a poor outcome. So there is a heterogeneity in immune responses there. Most of these people have some comorbid conditions, diabetes, cancer. They are going through some sort of treatment. Age and sex are another other risk factors, and a bunch of other things. Whatever diagnostic we develop, it has to work in this very heterogeneous patient population. We cannot have different diagnostics for different group of patients. It's going to be very expensive. It's going to be slow. What we need is something that works across the broad patient population. And that's where this publicly available data was the key. That was the second insight for us. that if we had to go and enroll this very heterogeneous patient population, it's going to be logistically very expensive, time consuming, and we won't be able to move fast. So publicly available data was the key. That what we need to do is we need to embrace heterogeneity that exists. Usually, people would tell you that you cannot have a lot of heterogeneity in your data or confounding factors, that's the other name. But in biomedical research, I propose to you that we have to start with as much heterogeneity as possible if we want a good probability that when you go in real world patient population, it will actually work. And publicly available data was the key, because different labs, the way the academia works, people are competing with each other, not trying to get their paper scoop. So they enroll slightly different patient population, right? Enroll in inclusion-exclusion criteria slightly different, different age groups, different severity, different disease duration, different treatment protocols. Think of the confounding factor that we usually try to control in our analysis, but that's what is present across different data sets collectively. So if you zoom out, collectively, all of these data sets actually represent what the real world patient population is. People also have different technology that they prefer. So that introduces technical heterogeneity. And we had a very simple hypothesis that if there is a signal, generalizable signal that exists for a given disease, it should overcome all of the heterogeneity, the biological, technical, and clinical heterogeneity. And the very simple framework, very simple hypothesis was, if we started with green and blue people, not just green, not just blue people, but all green and all blue people, then not only we know it will work in green and blue people, but it has a higher prior probability that it will also work in orange, purple, yellow people. That was the simple hypothesis. But what was needed is when you look at the methods that we have developed, they require that your data does not have any confounding factors. Batch effect is another thing that everybody has thought about. If we are using different data sets, each data set is generated independently, different time points, that's a batch effect. How are we going to correct for it? I won't go into all of those technical details, but I would only say that for the last 15 years or so, we've also been in parallel developing methods that think of this heterogeneity as a blessing and not the curse between data sets. That because we have multiple data sets with different confounding factors, that's a blessing. And we should be able to find a signal that takes advantage of that heterogeneity. So using those methods and using publicly available data for the infectious diseases, we just annotated more than 25,000 patient samples. Every inhabited continent, more than, these numbers are now old, but more than 30 countries, every age group, disease comorbidity, all the confounding factors that you can imagine being there. More than 50 hospitals that these patients were enrolled in. But these are all not, this is not one giant study, right? These are many small independent studies that have been carried out. And most importantly, we made sure that we are not diagnosing between infection versus healthy. That's not the clinical question. The clinical question is, when somebody shows up with an acute febrile illness, can I identify whether it's an infection or not and what kind of infection it is? So the control cases are non-infectious patients, but still inflamed. We collected all of this data. All of this is available, very well curated. We've scoured supplementary tables, begged, borrowed, threatened people to give us the patient metadata, created this database. We have the methods, and we just went on a idea that we should be using this data. We should be able to really create a phylogeny of host response, if you will, to be able to say, when somebody presents with an acute illness, does that patient have infection or not? What kind of infection it is? We have even been able to show that just by reading the immune response, we could diagnose what the patient has, what bug the patient has, not just the class, but actual bug. Series of manuscripts to really show that immune system actually knows what's going on. If you sum up the number of genes for each of these signatures, it's less than 50 genes. And if you could somehow measure these 50 genes at point of care in 30-minute turnaround time from blood, the number of cases, the number of cases per year for just the infectious diseases I've listed here are 2 billion cases per year annually. It's a huge global health problem that we can address. Every one of these signatures, and a few things to remember or point out, not a single data point generated in a lab. All of this data is publicly available. Only human data. Every heterogeneity inducing factor accounted for. And every one of these was prospectively validated by one of our collaborators, many of them at Stanford, but also at other institutions. And that was remarkable, that every single one of these gene signature has been prospectively validated. So then the next question was, could we, instead of each paper is one signature, fine, but could we bring all of this into a single diagnostic test so that you don't have to run different classifiers, as I was saying earlier, but you can have one diagnostic test, one classifier that allows you to answer 3 questions: presence, type, and severity of infection when a patient presents in the clinic. So that's what we started working on. Using the methods that we've developed, we chose 3 of these gene signatures and really demonstrated that a gene signature for diagnosing sepsis compared to SARS patients, a gene signature for diagnosing whether somebody has a bacterial or viral infection, and another 11 gene signature for predicting risk of 30-day mortality at presentation, only at presentation in ED or admission to ICU. And then a lot of machine learning, data science, AI to ultimately merge these gene signatures into a single classifier, irrespective of what the patient population is, immunosuppressed or not, age, just a single classifier with locked thresholds for all of us. But so now we have data, we have methods, we have a classifier built, all of that is done, but we cannot measure gene expression at point of care in 30-minute turnaround time from a single blood draw. No platform exists. We actually tried to talk to a lot of diagnostics companies, and we basically talked to majority of these at Stanford after we disclosed. Stanford OTL talked to majority of these companies, and anytime, as soon as they all heard its gene expression, they all walked away, never to be heard from ever again. And here is the problem, right? You need to be able to measure 29 genes at point of care in 30-minute turnaround time. There are platforms like SafeFeed and BioFire have platforms that they can measure a few genes, 3 to 4 genes at point of care from a blood draw. It takes about 2 hours, but you can do it. Oops. The friend's gone. Okay, no, it's here, it's fine. There, okay. But they need to, and in some of these platforms, like Abbott's platform, it requires that you have a few patients before you can run the sample. Or you can do high multiplex, but you usually have to send the samples up. So that's where, when nobody would license this, Tim Sweeney, who was a postdoc in my lab at the time, and general surgery resident, a fourth-year general surgery resident at Stanford, we talked and we decided that we will have to do this ourselves. So we started Informatics with the goal of building a platform to be able to measure gene expression at point of care from a single blood draw in 30-minute turnaround time. And I'm very excited to say that we did build a platform. Now we have a device that can measure up to 64 genes. Each of those small dots on the cartridge is one well, one gene. The total hands-on time is less than a minute now. After the blood draw, directly in a vaccine tube, you put the tube in the cartridge. There is a hepatic feedback to let you know that yes, it's in full inserted. And then you insert the cartridge in the machine, runs all of the machine learning on the device, and in 30 minutes, it gives you 3 scores. Probability of bacterial infection, probability of viral infection, and risk of requiring ICU level care in next 7 days. 3 scores. And the reason for doing this, 3 scores instead of 1, is to answer 2 questions, not just is this sepsis or not. It's never that. It's not only is there an infection or not, and the risk for mortality, risk for severe outcome. You need these 2 answers to be able to say, it doesn't look like infection, and it's not severe, so maybe we should send the patient home and do additional diagnostic. Or it is infection, it looks like bacterial infection, and but it's low severity, so prescribe antibiotics, send home. Or it's not infection, but the risk of requiring ICU level care in next 7 days is high. So maybe we admit and then do additional diagnostic and so on. So these 2 questions using 3 scores allow us to ask many different questions in clinical practice. We even received FDA breakthrough device designation. And then the question was, this is all well and good, but does it actually work? So a lot of discussions with FDA, ran first a pilot study to demonstrate that this is what it roughly does. It seems to be working. There is fresh, frozen, whether it's a fresh sample or a frozen sample, there is equivalence. And then I'm going to walk you through some results. These were pre-planned, pre-described analysis from FDA for the clearance. The papers on not bioRxiv, Research Square, all the results are there, and I'm just going to walk you through a few of those. So this pivotal trial, 1,200 patients across 22 clinical centers, enrollment criteria, either 1 abnormal sign and suspicion of infection, or 2 abnormal sign and a blood culture was ordered. So that was the enrollment criteria. Not excluded for immunocompromised status, included everybody. And then the blood sample was taken in a vaccine tube, ran on Myrna instrument using Trivarity. Basic demographics, right? Broad age range, it was only adults, 18 to 90 years, about 52 years median age. Roughly 50-50 male, female, a lot of whites, but also 30% blacks and other races and ethnicities. And about 20% of these patients had immunocompromised status. And really, it represented what we would expect in an ED. About half of them were admitted to ward, 13% or so were admitted to ICU, a quarter or so were sent home. And here are the 3 scores, and then each score is 5 bands, very low, low, moderate, high, and very high, each of these 3 scores. And the specificities and sensitivities. So when the test comes back positive for a given score, very high specificity, meaning you are not unnecessarily treating people. So when the test comes back negative for a given score, very high sensitivity, saying there aren't many false negatives. Overall, way better than what we would have expected. But what was one of the exciting results was when you compare to PCT CRP, we could show, because we had accounted for heterogeneity upfront, the biases for different races, different ethnicities, were actually minimal compared to PCT. So for example, PCT, not only overall gene expression trivality test is better than PCT, but also has more comparable accuracy across different races. Same with CRP, overall reduction in both false negative and false positive. All the exact numbers are in the paper, but this was ultimately, this is the ultimate message, that across 1,800 patients, 2 registered trials, we could show that trivality does 2 things. It identifies people who were adjudicated as not having bacterial infection but were given antibiotic. So it says these are the people that should not get antibiotic, but also identifies people who were adjudicated ultimately as having bacterial infection, not given antibiotic. You are able to identify those, both of those, so false negative, false positive, for antibiotic treatment correctly. Dramatic improvement, more than 65% improvement. One of my favorite number is the reduction in false negative for ICU care. Out of these 1,200 patients, there were 26 across 22 EDs that presented at ED. None of the clinicians at different EDs thought that they were severe enough. Their lactate was less than 2, QSOFA 1 or 0, so less than 1, and they were sent home. And of those 20, and there were 26 such people who died. Trivality picked up 18 of those people as they are severe, don't send them home. So we reduced the false negative. When the clinician could see the patient, could see their symptoms, could look at their test and judge they are fine, they can go home, we would have identified 70% of those patients molecularly. And that's one of the biggest, that's one of my favorite numbers to talk about, that we could have saved 18 lives out of those 26. And reducing false positives similarly. So this is all good, but there is still one more problem. So this is all sort of published, right? And now I'm going to switch into what more we can do now that we have a platform. We can quantify immune status at point of care. What else can we do? So the reason, one of the reasons that infectious disease continue to be a global health challenge is here, right? Even if we can diagnose correctly, the mortality has not changed over last 30, 40 years, except for the children under the age of 5. Mortality has more or less remained constant since 1990, almost more than 30 years. So what's going on? It cannot only be diagnosed, not our ability to diagnose correctly. The other thing is probably treatment. And there have been so many trials done for treatment of septic patients. And just the literature is full of this, right? And all of them have failed. And then the question becomes, what's going on? Andrew, who's sitting here in the audience, pointed out this paper, this perspective in Lancet, that the math doesn't add up. If you toss a coin 20 times and every time it comes back tail, you know that something's wrong with the coin. statistically that's happening is unlikely. If you keep doing the clinical trials and they all fail, something's wrong. And when you look in literature, the consensus is that it's not, there is so much heterogeneity in patient population and in their immune status and immune responses that not everybody responds to every drug. We know this. It's the heterogeneity of treatment effect. So we said, now that we can diagnose any infection, we can risk stratify, we can measure it at a point of care, we should actually be able to reduce this heterogeneity in treatment. We should be able to identify groups of patients and demonstrate that we can improve therapy response. Again, we are not the first ones. For some reason, there is a lag between here and there. So we are not the first one, right? A lot of people have been trying this for at least 2 decades to find homogeneous group of patients that are molecularly similar and have a likelihood of responding to treatments. 2 of these gene signatures, the SOM and SVD endotypes, are from our lab. And these efforts, when you go back and look at what's going on, all of these efforts have a few things in common. They find anywhere from 2 to 4 groups, and they say, this group has good outcome and this group is going to have bad outcome. Can do that, that's fine. But when you look under the hood, genes don't overlap, very minimal overlap. Also, they use different patient populations. Speaking just as an example from our lab, SOM signature was using only viral infections, and SVD endotype was using only bacterial infections. So if we even use different patient population, one time we found 4 clusters, the other time we found 3 clusters. What is right? So Tim Sweeney, who was a surgery resident at Stanford and quit and now runs Informatics, and Angela Rogers at Stanford in ED. I think almost everybody knows her. And we decided to start this thing called SUBSPACE Consortium. Please don't ask me what it stands for. But the idea is it's a consortium of 10 institutes where everybody donated their samples and data was generated. And all of the work that I'll talk about now, almost everything is done by Andrew, who's here, a postdoc in the lab, attending in ICU. I always have to remind myself that he's an actual doctor, unlike me. I'm a phony doctor, the PhD, right? So Andrew's done all of this work. And the idea is very simple at its conceptually. What we are going to do is we are going to collect this large amount of data, including these 3,000 samples that have not been published ever before. They have not been profiled, and really compare all the transcriptomic signature schemas that have been proposed for endotyping patient population with sepsis, apply different methods to really see, are there really 21 different groups of patients? Or really there is some meta cluster that everybody has basically been identifying the same set of patients. The analysis is too long, the paper's on bioRxiv, so I won't go through everything, and I'll only focus on completely novel data, but everything was done twice, public data and prospective cohorts. So these are the SUBSPACE data sets, very heterogeneous. Again, where you can see pediatric, adult sepsis, bacterial sepsis, COVID, even trauma, coming from different countries, about 3,000 samples. And what Andrew showed, the first thing, so what he did, every patient got assigned, basically calculated each one of those scores from all 7 signatures and just did a hierarchical clustering. And something remarkable popped out. First thing, every signature identifies this cluster that patients in this cluster tend to have bad outcome. This greenish, two greenish looking clusters, those are the patients that tend to have good outcome. And this one is somewhere in the middle. It's not as good as the green and the blue, but not as bad as the red one. Apply two other methods, principal component analysis, network analysis. No matter what we do, it's exactly the same result. So then the question was, what is the underlying biology? Is this the same? Why, if they look the same, why don't we have the similar overlapping set of genes? So Hong Zhang spent 2 years collecting, again, publicly available data, but single cell from COVID and bacterial sepsis patients where neutrophils were profiled at a single cell resolution, which is one of the most challenging things because you can't store neutrophils. They have to be profiled fresh. So that was the key. And what Andrew found was the genes that define this bad cluster across every gene signature, every schema, although genes don't overlap, they all come from the same immune cell type, immature neutrophils and a popular subset of mature neutrophils. Patients in the cluster that tend to have good outcome, those genes tend to come from the same T and NK cell clusters. Or this another good outcome cluster where the genes, yes, they come from neutrophil and monocyte, but this population of neutrophil and monocyte is different from this. So there is commonality across all of these at a single cell resolution. We've all been looking at the same elephant, but from different angle. I don't want to call everybody blind, but it's the same thing that we've been, just because we use different patient population, different severity, different methods, we've been looking at the same thing. So given this, Andrew went back and said, okay, so we are going to look for genes that are specific to immature neutrophils, mature neutrophils, monocytes, and then T and NK cells. We're having a hard time finding only T, only NK cells that were relevant to what we were doing. So it's just merged into one. And then some of genes are, excuse me, detrimental, some are protective. We computed scores. We won't go into those details. But came back, and then now we have 3 scores. When a patient presents, their immune system could be dysregulated along one of 2 axes. Their myeloid system could be dysregulated, or lymphoid system could be dysregulated. And if you look at the risk of 30-day mortality in all of these prospective cohorts, they are both associated with poor outcomes. So the higher the myeloid or lymphoid dysregulation score, higher the risk of mortality, 30-day risk of mortality. So collectively, this gives us this framework now, where when a patient presents, you could measure their immune response and quantify along 2 axes. And we can argue that maybe it's actually 4 axes, right? Look at each immune cell type separately. We can do that. But this is a proof of concept trying to demonstrate that this framework is flexible and has a lot of potential. So now if we assume that a patient comes in, we measured these 2 scores, we can now put them in one of these 4 buckets. Their immune system's doing what it's supposed to do. One arm of the immune system is dysregulated, or the entire system is dysregulated. But what we need is these dotted black lines, and it's calculated very simply. Just look at all healthy people across all the data sets and just choose 95th percentile as the threshold. So that's these black dotted lines, 95th percentile of healthy people. And then the idea would be severity of outcome, death, need for ICU admission, all of that would be lower here, higher in if only one of the arm is dysregulated, and the highest if there is a system-wide dysregulation. That's the hypothesis. How does it work? In all of the SUBSPACE data, that's exactly what we see. If your immune system is doing what it's supposed to do, mortality less than 10%. If there is system-wide dysregulation, mortality rises to 30%. But this is infections, right? Sepsis. What if there is immunosuppression? So we had two cohorts in SUBSPACE where we actually knew patients' immunosuppression status. So the gray ones are immunocompetent. It's exactly as we would expect, lowest here, highest here. But the same trend is also present in immunocompromised patients. If immune system overall is doing what it's supposed to do, even if you are immunocompromised, mortality is lower. And as immune system gets more dysregulated, severity increases in two different cohorts. That is all infection. What about other critical illnesses that land you in ICU? Burn, trauma, ARDS. Exactly same relationship. If your immune system is doing what it's supposed to do, mortality, severe outcomes lower. One or both arm dysregulated, severity and mortality goes up. So this is all critical illnesses that you can imagine being in the clinic. Can we improve? And again, one more time. Can we improve treatment response? Can we predict treatment responses? And is that really true that this would actually work? So the hypothesis is people whose immune system is dysregulated are the ones who would benefit from a treatment, immunomodulatory treatment that you would give them. So we simply divided patients into low as in less than 95th percentile. So the lymphoid dysregulation is, there is no lymphoid dysregulation, or high lymphoid dysregulation, greater than 95th percentile of healthy people. This was a trial, phase 3 randomized controlled trial for anakinra in COVID in Greece. We profiled day 0 samples, 400 patients that were randomized to standard of care or standard of care plus anakinra. And all of the benefits of anakinra treatment comes from the patients who had lymphoid arm dysregulated. Hazard ratio 0.08. What about steroid? We found that in one of the studies, it was a longitudinal study, that the steroid reduced lymphoid dysregulation after 7 days of treatment. So again, the same hypothesis that people whose lymphoid arm is dysregulated would benefit from steroids. So this is another randomized controlled trial out of Johns Hopkins. We profiled their day 0 samples at ICU admission. And then they were randomized to steroid. And once again, patients whose lymphoid arm was dysregulated is a group that actually benefit from steroid treatment. But we don't have to stop here. We can even go further. We know that there are risk factors for severe outcome: age, sex, BMI, smoking, having any other disease. So we asked a question, this immune dysregulation, is that only when you have infection, or it exists before you get infected, when you have a risk factor, and that is what increases your risk for severe outcome when you get infected? So we use Framingham. I think everybody knows here, Framingham, one of the largest running cohort studies. 5,300 people across 2 generations, offspring and generation 3. And we could show that if you have any of this risk factor present when you have no infection, that immune dysregulation is already significantly higher in those people. So this immune status is already there before somebody gets infected. But what's more interesting is as the number of risk factors increase. So if you are healthy young woman, let's say, right? That's sort of the reference group, that they have the lowest risk for severe outcome when they get infected. Compared to those, if you are now male, obese, smoke, and are old, so 4 risk factors, both your myeloid and lymphoid dysregulation is significantly higher. So as the number of risk factor increase, immune dysregulation also increases before you get infected. And we can start thinking about how to leverage this in clinical practice. One final thing, and then I'll stop. So this was a remarkable result that every signature is identifying immature and mature neutrophils. So the question was, we actually measure neutrophils in CBCs with data. So can we actually use that? Can we improve its utility? So Atropos, which is actually co-founded by Nigam, and in one of our weekly hikes, I mentioned this one. I said, well, just submit a request, and I should, for all the trainees, you can do this yourself for free. And it doesn't have to be just trainees. Anybody can actually submit this request for free. So Andrew submitted a request to analyze across 2 data sets, only CBCs from 2015 for those who were 18, had no Charleston comorbidity as at least in their electronic health record, and only normal neutrophils, okay? Not abnormal high or abnormally low, just normal neutrophils. And asked, see if being in a 4th quartile of high neutrophils is associated with increased risk of developing any of the Charleston comorbidities and mortality. And a lot of sensitivity analysis across both cohorts, well over 200,000 people. The Stanford is 137,000, that's even larger. Consistent result. If your neutrophil count, although it's normal, but it's in the 4th quartile compared to 1st quartile, you are 27% more likely over the next 10 years to develop one of the Charleston comorbidities. It also predicts all-cause mortality. We could only do it in Stanford cohort, but just being on the 4th quartile of neutrophil count, absolute neutrophil count, almost double the risk of dying. And here are additional analysis just to show you that even when you look at individual comorbidities, being in 4th quartile means you are at a higher risk. Even when you compare 1st quartile versus 2nd and 3rd quartile, it still remains high. These numbers are smaller than this, so you can imagine there is a gradient, right? As you go from 1st quartile to 2nd and 3rd to 4th quartile, your risk of developing these chronic conditions increases. And that holds true for any of the sensitivity analysis. Normal BMI, young, middle-aged, old people, doesn't matter. Green means it's statistically significant. I'll stop here and say, hopefully I convinced you we need to account for heterogeneity upfront. Ton of data already exists, methods exist that we can start leveraging this heterogeneity. We actually now have a platform that can measure immune status at point of care in 30-minute turnaround time. It just opens up so many opportunities to really bring science of medicine to practice of medicine and ultimately deliver it to the patients. And then some really exciting results in terms of conserved immune dysregulation in both health and critical illnesses. People who actually do all the work and allow me to say we did it. Every time I said we today, it's a royal we. I do nothing. Especially Andrew Hong and Anant. Really, it's one of the best thing about Stanford and the department is being able to work with just people just walk in through your door and say, can I work with you? And then a lot of people, especially collaborators who take this data, pure computational analysis, and actually enroll patients, do the studies, and really show that these things are actually useful for patients. Thank you.
All right. Thank you so much, Dr. Khatri. Questions from our live studio audience? let me run the mic over.
Purvesh, that was a great talk as usual. Thank you very much. Andrew Moore and Angela Rogers and I have been talking about an increasing phenomenon. I'd love to get your perspective on it. We have medical students, residents, fellows listening to your talk, And the problem that we're encountering over and over again is this burgeoning field of machine learning and how much time it takes to learn. That's one fact. But then another fact is the emerging public availability of getting some of these things automated. And they're faced with a decision if they want to stay in academics. How do I jump into this? In what percentage do I do this and learn all about this? And how much do I have to learn about the disease process or immunology or genetics? How do I balance my training?
Yeah, I mean, so I'll answer the second question, right? How much immunology I have to learn, how much machine learning I have to learn. So I'll answer this with an example. I'm an electronics and communications engineer who became a software developer, then bioinformatician, came here for organ transplant to Stanford, became a transplant medicine researcher, and now I call myself computational immunologist, right? I have no biology background, no immunology background, no statistics background. Just do the work and learn as it's needed. One of the things that I've found that has really helped is sometimes knowing too much actually puts blinder on your overall view when you're looking at data, versus being more blank slate tremendously helps because you are naive. And if it's something that's already been done, then you know that you are on the right path. So that's one thing. Second, where do I start? How much time do I put in? I think the better people who can really answer that better, and I'll still give an answer, are the trainees from my lab. So for example, Andrew is sitting here, and Andrew can tell you about 2 years ago, he didn't know much about it. And now he actually teaches me as to here is the right thing to do. What I have seen, I ran the computational systems immunology program, a graduate program for immunology for almost a decade. And what I saw was students coming in, it takes them about 3 months to learn programming, another 3 months to be comfortable. And in about 9 months, they are all off doing things on their own. What really helps is uninterrupted time. If there is interruption, then it doesn't work out. So they need more like a big chunk of uninterrupted time that they can continue to, and that has been the key. And I'm happy to talk more. I want more people to do this. We are not going to be able to do every disease, but everything's there. And
Okay, sorry. One question actually from our virtual audience was from Dr. Kim. She was asking about immunosuppression and whether in interpreting the results for risk of either sepsis or ICU admission, is there any adjustment for things like CD4 count or immunosuppression?
No, that was one of the things that we were expecting we would have to do. A locked classifier, and because it was FDA trial, we couldn't do that. Locked classifier, and it worked just as is. The data is in the paper. You look at the numbers, and there is minimal difference between immunocompromised and immunocompetent patients.
Hi, thank you so much for a great talk. I'm Beth Martin. I run our HLH program. So I was initially going to ask you a question about the public data sets for dengue and HLH, because that's spreading fear through the HLH community. I'm asking a different question. Is there a public database on NETosis? Because every single disease you listed in that, probably that's the high versus low neutrophil, I would suspect, although I've got a better expert here, my division chief, to comment on that, but it's probably NETosis. And I think it's at least part of it because it's so prothrombotic.
So there wasn't a NETosis data per se. We could only look at the gene expression. But I have the same suspicion that either it's NETosis is increasing, but it's also possible just increase in neutrophil count is a danger signal that something wrong is about to happen.
Sorry, one last question.
Oh, sorry, go ahead. That's fine. That's fine. Yeah. Thank you for your interesting talk. In one place early on, you mentioned that you picked up 18 out of, say, 22 people that wouldn't have been picked up. And you assume that they would survive, but do you have any prospective data on whether this works? Because we want to see whether this is better than what already exists. So if those patients would die anyway, then then this is interesting, but it's not clinically relevant.
Well, so I'll answer first question. So we have now started an interventional trial where the patients are being treated based on what the trivality says. About 20% have been enrolled, 20 patients have been in. Control standard of care versus trivality saying treat them. So that's one. So that's going on. 3 hospitals are recruiting for that, 2 or 3. But the second one is, these are the patients that we actually asked clinicians, right? Why did you send them home? It wasn't that they were sent home because they were going to die. They were sent home because they looked okay. There was nothing wrong with them. Their Q-SOFA was low, their lactate was low. They didn't show any signs of having anything severe. The comorbidities were nothing to worry about. So these weren't the patients that were sent home to die, so to speak, because there was nothing else that the docs can do. They were sent home because everybody thought they were going to be fine. And those were the ones that we picked up, the 70% of the patients.
Thank you so much, Dr. Khatri. Please join us next week for Dr. Giselle Salmassi, who will be presenting grand rounds here in this room. Thank you so much. Have a great week.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.